Welcome to the Deep Dive, the place where we take complex, high-stakes clinical information and really distill it down to the essential knowledge you need to be sharp and well-informed.
Today, we are immersing ourselves in the dynamic world of cardiac surgery. We're pulling the key clinical insights from a really fantastic resource, Tanya Hodges' Fast Facts for the cardiac surgery nurse.
And our mission today is simple.
Yeah, it's to build you a comprehensive, clinically relevant roadmap. We're going to cover the entire patient journey. From the moment cardiac disease is identified all the way through the OR and into that crucial post-operative recovery phase.
And for anyone who's stepping into this field, whether you're a med student, a new resident, or even a self-taught learner just trying to get ahead, understanding this path is, well, it's non-negotiable.
It really is. Cardiac disease is still the leading cause of death globally. The knowledge we're covering today, it's literally life-saving information.
So where do we start?
Let's start right at the beginning, understanding why a patient even needs surgery. And the foundational pathology for most cases is coronary artery disease, or CAD.
Okay, let's unpack this core issue then. So CAD is defined by this gradual buildup of plaque inside the coronary arteries, the very vessels feeding the heart muscle itself. This plaque is this mix of fatty material, inflammatory cells, and then eventually calcium deposits that harden the whole artery wall. It's basically like corrosion that narrows the pipe.
Right. And that impedes flow. And when that lack of blood flow or ischemia becomes symptomatic, we see angina.
That classic presentation.
The traditional presentation, yeah. Chest pain or pressure, often radiating to the jaw, neck, or down the arm.
No.
And it's frequently accompanied by, profuse sweating diaphoresis or shortness of breath.
But this is where the clinical picture gets really interesting and honestly a bit risky.
Yeah.
We know that in certain populations, I'm thinking women, diabetics, and the elderly, the symptoms are often atypical.
Exactly. So instead of that crushing chest pain, the patient might present with just unexplained weakness or this overwhelming fatigue, nausea, indigestion, dizziness. Sometimes even just isolated back pain.
And for the frontline clinician, recognizing those non-traditional signs is so vital because they can easily mask a life-threatening ischemia.
Absolutely. That distinction leads us right into the difference between stable angina and what we call acute coronary syndrome, or ACS.
Okay, so stable angina is predictable. The patient feels pain when they exert themselves, and it goes away with rest or meds.
But ACS signals an emergency. It means an unstable plaque has ruptured, and that triggers a rapid, really dangerous clotting cascade.
So ACS is a spectrum then?
It's a spectrum, yeah. It goes from unstable angina, or USA, to non-ST segment elevation myocardial infarction and STEMI, and finally ST segment elevation myocardial infarction, the STEMI.
So it's not just about the letters, it's about understanding how much flow is blocked and why that demands a different action. So how do we differentiate them clinically?
Well, it all comes down to the clot and its permanence. In unstable angina, the clot forms, but it spontaneously resolves before causing permanent muscle damage.
Okay.
In STEMI, the clot partially occludes the artery. It causes some ischemia, you get that troponin leak, but some blood flow is maintained. But in a STEMI, that clot creates a complete catastrophic blockage.
And that's when time truly equals muscle.
That is the moment. And that urgency dictates our benchmarks. For a STEMI patient needing rapid revascularization, if you're using thrombolytics, the door-to-drug time must be under 30 minutes.
And if they're going for PCI, the angioplasty.
The balloon time. That has to happen within 90 minutes. That window is just intensely narrow. It requires seamless coordination from the moment that patient hits the door.
Okay, so let's set aside the arteries for a moment and pivot to the heart structure. Cardiac surgery is also heavily driven by valve disease.
Right. And valves, they really have two core problems that lead to surgical intervention.
The first is stenosis, where the valve can't open fully. It impedes that forward flow like a stuck door.
Exactly. And the opposite is insufficiency or incompetence or regurgitation, basically where the valve fails to close completely and it allows blood to flow backward.
Mitral regurgitation is a common example of that, I think.
Very common one, where blood leaks back into the left atrium instead of moving forward into the ventricle where it's supposed to go.
And when we look at specific surgical conditions, something like mitral stenosis causes pressure to build up in the left atrium, which often leads to pulmonary congestion and a high risk for atrial fibrillation.
And then you have aortic stenosis. This is frequently caused by calcification in older patients, and it obstructs the flow of blood, leaving that powerful left ventricle.
So the ventricle just struggles. It hypertrophies.
Exactly. And patients experience angina, syncope, and they're at risk for sudden cardiac death. And here's a critical fact the source emphasizes. Severe aortic stenosis must be replaced. It cannot be repaired or patched up.
We should also probably touch on the growing complexity of adult patients with congenital heart disease, or CHD.
Oh, absolutely. It's crucial for the surgical team to recognize any prior intervention stents, occlusion devices for septal defects, prior repairs, because these things significantly complicate any new surgical approach.
The history of the heart matters just as much as its current state.
So true. And moving from that pathology to the preparation, the diagnostic process follows this deliberate tiered approach. You start with the least invasive, and you only move to invasive if the results are concerning.
So on the non-invasive side, we're using tools like the exercise stress echo, watching for wall motion irregularities when the heart is under stress.
Right. And myocardial perfusion imaging, which uses radioactive tracers like thallium-201, that gives us a map, essentially, showing which part of the myocardium is viable versus what's already infarcted.
But the gold standard for defining the coronary anatomy is still cardiac catheterization. It's invasive, but it gives the surgeon the map they need.
It really does. So we usually access the arterial, system femoral, or radial artery for the left heart cath. This lets us perform coronary angiography.
Which is the direct visualization of the arteries.
Direct visualization of the coronary arteries or any existing bypass grafts. And crucially, we also get the left ventriculogram to calculate the ejection fraction.
And at the same time, a right heart cath is measuring pressures on the venous side. What kind of difference are we talking about, pressure-wise?
Oh, it's vast. I mean, to give you some context, the left ventricle systolic pressure is typically around 90 to 140 millimeters of mercury, while the right atrium mean pressure is only 3 to 8.
Wow.
Yeah, that comparison gives us essential functional data about the heart's pumping and filling efficiency.
Let's talk about preparation, the details that prevent disaster. The source really emphasizes documenting a baseline neurological status and checking blood pressure in both arms preoperatively.
That bilateral BP check is a fantastic practical takeaway. A significant difference between the arms can indicate subclavian stenosis.
And if that's present,
It means the surgical team cannot use the internal mammary artery on that side as a graft. The blood flow would be compromised, so that forces an immediate change in the surgical plan.
and of course, infection prevention is paramount. The stakes here are shockingly high.
They really are.
We know that a superficial wound infection is serious, but a deep sternal wound infection, a DSWI, carries a mortality rate that can be as high as 47%.
That risk just completely reframes the entire preparation process. It absolutely does. Strategies like chlorhexidine washes, clipping hair instead of shaving, and making sure those broad-spectrum prophylactic antibiotics are infused within 1 hour of the incision, they're not optional. They are critical survival steps.
So all of this preparation leads to that core strategic decision. When do we choose CABG coronary artery bypass grafting over PCI or stenting?
Well, PCI is great for focal lesions, but CABG is indicated when the disease is really diffuse or when a patient has left main artery disease, so an occlusion greater than 50% or significant disease over 70% in 3 major coronary arteries.
And it's also the go-to if they're already opening the chest for another procedure, like a valve.
Exactly. It's the preferred option then.
Okay, so if CABG is the choice,
Right.
the specific conduits that are used are key to the graft's long-term success.
The internal mammary artery, or IMA, is preferred. It just lasts the longest. But, as we just mentioned, there's a trade-off. Harvesting it increases the risk of that sternal infection.
Then there's the radial artery.
Right, the radial. It's a durable artery, but it has this tendency to spasm. So before harvesting it, the surgeon has to confirm the ulnar artery is patent by performing the Allen test.
And if they use the radial artery, those patients need post-op vasodilators like nitroglycerin or diltiazem to prevent that acute spasm.
That's right. And the saphenous vein graft, or SVG, is a third option, used when arteries aren't available. But, generally they just don't last as long as the arterial grafts do.
Okay, turning to valves now. Patients face this necessary trade-off between tissue valves, usually from a pig or a cow.
Porcine or bovine, yeah.
Right. And those don't require long-term anticoagulation. but they only last up to about 20 years.
Versus mechanical valves, which are incredibly durable, excellent for younger patients, but they absolutely mandate lifelong anticoagulation, usually warfarin.
Because of that high risk of clots forming on the valve surface itself, that decision involves a serious lifestyle discussion with the patient.
A very serious one. And we should briefly mention the minimally invasive alternatives for high-risk patients. TAVR, the transcatheter aortic valve replacement.
Which is often used for elderly patients with severe AS.
Exactly. And the MitraClip procedure for severe mitral regurgitation, which just clips the valve leaflets together without open surgery.
So now we move into the immediate postoperative phase, the ICU, and the priority shifts to hemodynamic stability.
Right. We are constantly monitoring and optimizing cardiac output, or CO. And you have to remember, CO is governed by preload, afterload, contractility, rate, and rhythm.
So when that CO drops, we have to follow a very deliberate hierarchical approach, and the first step is
always addressing preload. Low CO is most commonly caused by decreased preload. Could be from vasodilation, bleeding, or third spacing of fluids.
And we treat that with volume replacement.
We initiate treatment with crystalloids. And here's a crucial detail for you. Avoid large volume chloride-rich IV fluids like normal saline. They can cause a hyperchloremic acidosis and worsen acute kidney injury.
And if fluids fail,
then we escalate to vasopressors like norepinephrine or Levophed.
And this is where we get into some really advanced material, vasoleakic syndrome. This is a profound, dramatic vasodilation that is refractory. It just doesn't respond to the standard pressors.
It's an absolute emergency, and the source notes that it can be treated with methylene blue.
So once preload is optimized, then we look at afterload.
Right. High SVR systemic vascular resistance is treated with vasodilators like nitroglycerin. And it's only after preload and afterload are optimized that we reach for the inotropes like dobutamine or milrinone to boost contractility.
Speaking of emergencies, we have to watch for two critical initial complications. First, cardiac tamponade.
Yes. This happens when blood rapidly accumulates in the mediastinum, and it's often because the chest tubes have clotted off.
And this blood constricts the heart, critically reducing preload.
And the classic clinical alert here is a paradox. You see a sudden drop in chest tube output, but the patient suddenly becomes hypotensive and tachycardic. That demands immediate surgical reexploration.
The second acute issue is coronary vasospasm.
This presents as a sudden drop in cardiac output and hypotension, and it's accompanied by that telltale sign on the EKG ST segment elevation. Immediate vasodilator therapy is what's required here.
Okay, looking slightly further out, arrhythmias are, well, they're practically guaranteed.
Pretty much. Atrial fibrillation is the single most common complication, affecting 30 to 40% of patients, and it typically develops around post-op day 3.
Often triggered by the inflammation from the surgery itself.
Exactly, especially after valve surgery. Treatment for AFib focuses on rate control with agents like beta blockers or diltiazem, and we also have to stay vigilant for the life-threatening ventricular arrhythmias, VT or VF.
Which requires immediate ACLS protocols and correcting underlying electrolyte imbalances, especially potassium and magnesium.
Always check the K and mag. And on the hematological side, we must be absolutely vigilant for heparin-induced thrombocytopenia, or HIT.
This is the ultimate clinical paradox.
It really is. Despite seeing a drop in the platelet count, so less than 150,000 or a greater than 50% drop from their baseline, this is a prothrombotic condition.
So the danger isn't bleeding, it's massive clotting. Clots that can cause an MI, a stroke, or even limb loss. Recognizing that paradox is crucial for timely alternative anticoagulation.
So as the patient stabilizes, usually by post-op day 1 or 2, they move out of the ICU to intermediate care. This transition is a highly vulnerable time.
And communication failures are responsible for an estimated 30% of all malpractice claims.
That statistic just hammers home the need for standardized communication. Using a format like SBR situation, background, assessment, recommendation is essential to ensure a structured, clear handoff.
Once they're stable, the focus shifts to recovery milestones.
Right. The urinary catheter should be out by POD2 to reduce infection risk. Epicardial pacing wires are usually removed around POD4 or 5, but critically, they must be electrically isolated taped down when not in use to prevent any electrical conduction risk to the heart.
Activity becomes a primary goal. We're pushing for progressive ambulation, aiming for the patient to walk in the hallway at least 4 times a day by discharge.
And we have to strictly enforce sternal precautions. no lifting more than 10 pounds, and avoiding any pushing or pulling movements for 6 full weeks to make sure that sternum heals.
And throughout all of this, glucose control is essential for preventing complications.
It's so important. Stress hyperglycemia is incredibly common, even in patients without prior diabetes, and the goal range has to be maintained tightly between 140 and 180 to support healing and reduce infection risk.
And finally, the journey concludes with cardiac rehabilitation. This isn't just exercise. It is the cornerstone of secondary prevention.
It's all about optimizing those modifiable risk factors to minimize future cardiovascular events. And the goals are evidence-based. For lipid management, we target an LDL cholesterol less than 100, or even aggressively less than 70 for high-risk patients, like post-CABG.
Blood pressure control targets less than 130/80.
And the lifestyle changes are formalized. Patients need counseling to achieve 30 to 60 minutes of moderate-intensity physical activity at least 5 days a week.
Anticoagulation remains key for specific groups, too.
It does. Patients with mechanical valves or chronic AFib require lifelong warfarin, or Coumadin, with very specific INR targets, often between 2.5 and 3.5, depending on the valve. This entire roadmap requires vigilance from the moment of presentation to years into recovery.
It's an enormous amount of sophisticated information, but understanding that flow, the pathology, the intervention, and the recovery crises is what separates a technically proficient clinician from a real expert.
So let's put this knowledge into practice. We'll do a final clinical synthesis exercise for you, the learner.
Okay, imagine this scenario. You are caring for a patient on post-op day 1 after a triple CABG. Their surgical conduits included a radial artery graft. The patient suddenly becomes hypotensive, tachycardic, and the EKG shows ST segment elevation in multiple leads.
Okay, so given their history and the graphs that were used, what is the most likely cause of this acute decline? And what specific class of pharmacological intervention should you anticipate needing to administer immediately?
That sudden drop in COP and the ST elevation, especially with a fresh radial artery graft, points immediately toward coronary vasospasm.
Exactly. And this means the immediate priority is reversing that spasm with a potent vasodilator, something like nitroglycerin or diltiazem, as quickly as you can.
That ability to link the type of graft to the potential complication is exactly the kind of deep synthesis we aim for.
An excellent wrap-up to our deep dive into the fast facts of cardiac surgical care. We covered the whole spectrum, from initial pathology all the way to long-term prevention. Thank you for joining us.